The goals for medical nutrition therapy for diabetes emphasize the role of lifestyle in improving glucose control with perhaps a secondary bonus of weight loss, better lipid panel profiles, and lowered blood pressure. The purpose of this presentation is to discuss the 4 overarching MNT goals for those with diabetes and how to prioritize the goals for each individual. Improving health through food choices and physical activity is the basis of all MNT recommendations for the treatment of diabetes. I will share with you 4 MNT goals, not in any particular order of importance, as determined by Everett and Associates in 2013. The first goal is to promote or support healthful eating patterns, emphasizing a variety of nutrient-dense foods in appropriate portion sizes to improve overall diet. We can go several different directions with this goal, as our client or patient might need education on what nutrient-dense foods are and/or appropriate portion sizes. The goal might need to further be clarified to specifically focus on attaining individualized blood glucose, blood pressure, or lipid goals, and perhaps to delay or prevent the complications of diabetes. As different as we are as individuals, the methods to assist our clients in achieving this goal are just as diverse. For some, we might want to promote the use of a simplified meal plan. Others might be MyPlate guidance, and others still might be increasing physical activities. For others still, we might educate on carbohydrate counting or using insulin to carbohydrate ratios. Generally, for those with type 2 diabetes, a reduced energy intake with carbohydrates spread out equally throughout the day is the starting point, as this will help to moderate energy intake while providing a carbohydrate load steadily throughout the day. For those with type 1 diabetes, carbohydrate counting is used to adjust the pre-meal short-acting bolus of insulin in addition to the longer-acting insulin. The second MNT goal is to address individual nutrition needs based on the individual's personal and cultural preferences, their access to healthful food choices, their literacy in terms of their health literacy as well as their numeracy level, and their willingness and ability to make behavioral changes. As practitioners, we must look at the whole client. We must see the client as an individual and not as the disease state. Spending time getting to know your client as an individual, their food preferences based on food availability and culture is paramount. As dietitians, we can plan a beautiful meal plan that meets all of the food groups with perfectly spaced out grams of carbs, but if the client doesn't have access to those foods, for whatever reason, maybe transportation, maybe they live in a food desert, or they just simply cannot afford them, then the chances of that beautiful meal plan that you spent hours drafting will not be followed, and a sense of despair or hopelessness might set in for both you and your client. Diabetes is a complex disease. The level of health literacy and numeracy is quite advanced. The disease itself is overwhelming with the hormones and the metabolic pathways and the complications due to poorly controlled blood glucose levels. Then you factor in the math that will need to be done every time the individual eats. Wow! As healthcare providers, we will need to gauge the individual's willingness and ability to make those behavioral changes, remembering that we need to start slow. The third goal is to maintain the pleasure of eating by providing positive messages about food choices while limiting food choices when indicated by scientific evidence. So with some individuals with diabetes, there are going to be substantial changes in their eating habits, perhaps going beyond just what they are eating, but when and how much they are eating. Do they nibble or graze throughout the entire day? Or do they mainly consume the majority of their calories once they get home from work? For some individuals, the greatest challenge might be the timing of the meals, whereas for others it might be that social pleasure of eating will be altered. Food is social, and for some, eating together is the mainstay of their social activity. We can remind our clients that all foods can fit in a healthy diet. We just need to know how to count the carbs and plan accordingly. The final MNT goal is to provide the individual with diabetes practical tools for day-to-day meal planning rather than focusing on individual macronutrients, micronutrients, or single foods. Again, all foods can be eaten in moderation. We need to remember that we eat food and not nutrients, so the focus must be on the food. At the time of diagnosis, the individual might have a steep learning curve related to knowing about the macronutrient composition of foods, how to grocery shop, or how to prepare meals. And this assumes that they have the money to purchase the food and have a kitchen to prepare the food in. So where do we begin when prioritizing the goals? Ultimately, the number one goal of diabetes management is to get the hemoglobin A1C values within normal limits. The effect of MNT on A1C levels will be known within 3 months. Research findings have shown that MNT can lower A1C levels the same as glucose-lowering medications such as metformin and glucophage. So the power of food is there. The larger MNT goal that is selected and then later broken down into smaller, more manageable SMART goals need to be client-centered. We need to consider the individual's age. For example, what we select for a child newly diagnosed with type 1 diabetes might be different for what is selected for an emerging adult with prediabetes or a middle-aged mom diagnosed with type 2 diabetes. The type of diabetes will need to factor in as well as the treatment protocol will vary based on the type. Weight status is crucial here as it can lead to comorbidities such as hypertension and perhaps a more advanced heart disease. Access to health care in terms of transportation issues or child care concerns or being able to get off time and or having insurance is critical as well. Healthcare professionals must be accessible. Is the individual's level of food security, how accessible their food supply and how nutritious is that food supply. Food pantries are a wonderful source of food for individuals and families, but unfortunately they may not have the foods needed for those with diabetes. The fresh fruits and vegetables, the whole grains, and the minimally processed foods. Additionally, the diagnosis of diabetes will impact the individual's quality of life for the remainder of his or her life. So a focus on overall wellness is becoming more of a mainstay in the treatment. This goes back to the importance of treating the individual, not the disease. As healthcare professionals, we need to think about the spiritual and emotional facets of diabetes on the individual and not just the nutritional needs and getting that A1C down by moving more and eating less. So this concludes the presentation of MNT Goals for Diabetes. Thank you for listening, and I hope you learned a thing or two.